Evening, everyone. My name is Shelley Dusick, and I have the honor of serving as the director of the American Cancer Society's National Roundtable on Cervical Cancer. I'd like to welcome you this evening to the first of our patient webinar series on cervical cancer information. Today's today's panel is going to be facilitated by Dr. Kayroll Gyan. Dr. Gyan is an associate director of the Phyllis F. Cantor Center for Research in Nursing and Patient Care Services and nurse scientist in the Department of Medical Oncology at Dana-Farber Cancer Institute. She is also an assistant professor of medicine at Harvard Medical School. Her program of research is focused on cervical cancer prevention among African American women, with a specific focus on social cultural determinants of health, such as culturally and contextually appropriate interventions to promote screening and symptom management. Her work has been published in peer-reviewed interdisciplinary journals such as Cancer, Causes and Control, Translational Behavioral Medicine, Social Science and Medicine, and the Journal of Cancer Education. Dr. Gyan earned her Bachelor of Arts in Africana Studies and Bachelor of Science in Nursing from the State University of New York at Birmingham, her PhD in nursing research from the University of North Carolina at Chapel Hill, and her postdoctoral fellowship at Harvard T.H. Chan School of Public Health. Joining her today is our expert panelist, Dr. Rebecca Perkins. Dr. Perkins serves as a steering committee member for the National Roundtable on Cervical Cancer and is also a professor of obstetrics and gynecology, at Boston University School of Medicine and Boston Medical Center. Her career is dedicated to reducing health disparities in cervical cancer. Her current research focuses on improving utilization of HPV vaccination and cervical cancer screening guidelines. Dr. Perkins is currently working on national projects related to HPV vaccination and cervical cancer prevention with the American Cancer Society, the CDC, HRSA, NCI, and the American College of Obstetricians and Gynecologists. She currently co-chairs the National HPV Vaccination Roundtable, and she was co-chair of one of the lead authors of the 2019 ASCCP Risk-Based Management Consensus Guidelines. She co-chaired the President's Cancer Panel Cervical Cancer Subcommittee and is currently co-chairing the Enduring Consensus Cervical Cancer Screening and Management Guidelines. She's also working with the U.S. National Cancer Institute on a multi-country project related to cervical cancer prevention in resource-limited settings. Doctors, thank you for joining us this evening.
Thank you for that wonderful introduction, Shelley. We're both happy to be here with you this evening. I'm happy to moderate this important conversation with Dr. Rebecca Perkins. As the webinar is called Cervical Cancer Basics, let's do just that and start with some basic terms so that we all have the same understanding as we continue this conversation this evening. So, Dr. Perkins, can you start our conversation this evening by telling us what is a cervix and where is it located?
Yes, I am happy to do that. Can you see my arrow moving around or no? Sounds like no. Okay, great.
No.
So the cervix is the bottom third or the bottom part of the uterus or womb. It is highlighted in the picture with the helpful red circle. And that is the part of the uterus that a gynecologist can see when they are doing a pap smear. So the cervix is located at the top of the vagina, and it is the part that is sort of protecting the rest of the uterus from the outside world, but it is also the part that is therefore vulnerable to HPV infections because it is directly there at the top of the vagina.
Thank you for that. And along those lines, can you tell us what is cervical cancer?
So cervical cancer is a cancer that develops in the cervix, and because of a lot of work from very dedicated researchers, we know that we sort of know the stages in which cancer happens in the cervix. So first, someone will get an HPV infection, and these are incredibly common. Pretty much everybody will have at least one in the course of their lifetime. You can have several, they can come and go. But usually over time, the immune system will control the virus and it will become inactive, and the HPV test will be negative. But for people whose immune system is not able to control the virus, either because they have a particularly aggressive type of the virus or because their immune system might be compromised in some way, or just, bad luck, the virus can go on and persist and cause changes in the cells that eventually can make them sort of grow out of control and become cancer.
Okay, thank you for that. Who can get cervical cancer?
So anybody with a cervix can get cervical cancer. So that means people who are born as women and have not undergone a hysterectomy, they are at risk for cervical cancer. On the other hand, if someone has had a hysterectomy for something like a fibroid or bleeding or something like that, then they do not, and their cervix was removed, they do not have a cervix, they are not at risk for cervical cancer. If someone has a uterus and they have undergone and they are transgender, so they identify as a man, but they still have their uterus and cervix in place, they also, because they still have a cervix, would need to be screened for cervical cancer. So it really just depends on the presence or absence of that organ and not how someone identifies themselves.
Okay, thank you for that. That's so important. When we look at the literature and health disparities for cervical cancer, we see that Black women and women of color are at experience higher cervical cancer mortality rates. Can you talk a little bit about, is one group of women at higher risk for cervical cancer, or what contributes to those disparities in cervical cancer?
So cervical cancer is caused entirely by HPV, or almost entirely by HPV, and anyone can get HPV. What we know is how to detect HPV and how to detect and treat cervical precancer before it becomes cancer. And so disparities in cervical cancer incidence and mortality are almost entirely due to disparities in access to screening and treatment.
Okay. Thank you. So it's not necessarily based on a person's background necessarily, but on their screening behaviors.
Exactly. It's not based on their background at all. HPV does not care. HPV treats everybody exactly the same. It's just whether or not someone has had access to screening and treatment. And now access to vaccination. Vaccination is critical. Every child between the ages of 9 and 12 should get their HPV vaccines, because it prevents not only cervical cancer, but cancer of the tongue and tonsils, cancer of the penis, of the anus, of the vagina, of the vulva, so many places you don't want to get cancer, and it prevents all of them pretty much 100%. So and the vaccine also will work beautifully in everybody. So all kids should get the vaccine, because then we will basically not have cancer in 40 years. It'll be awesome.
It would be awesome, and that's definitely the goal. That's definitely the goal. You mentioned HPV. Can you talk a little bit about what is HPV, the human papillomavirus, and who can be affected by it?
So technically, it is a double-stranded DNA virus. So it's a very tiny little virus. It lives on skin. It's transmitted with skin-to-skin contact. So people think of it as a sexually transmitted infection, and most commonly it is transmitted through sexual intercourse. However, my favorite title ever of an academic journal article was "Penis is not required, non-sexual transmission of HPV." And in fact, 50% of people who, if you're testing them constantly, will test positive for HPV before they have their first sexual intercourse.
Wow.
Yeah.
It's incredible. Thank you.
So men can get it, women can get it, everyone can get it. Everyone's going to get it. Everyone should get vaccinated. And if you have a cervix, you should get screened. Unfortunately, we don't have routine screening for the other HPV-related cancers at this time.
Unfortunately, yeah. And so, you know, we're talking about screening. Can you help, how can we help prevent cervical cancer? We know that screening is a big part of that. Can you say a little bit more?
Yeah, so basically cervical cancer prevention throughout the lifetime has two parts. The first part is vaccination at the age of 9 to 12. If you miss that boat, then screening is going to be your best friend. Screening begins between the ages of 21 and 25. If people are screening with Pap testing alone, it can start at 21, but at 25, you can start testing with the HPV test, which is more sensitive. So it picks up more precancers because it's not just looking for abnormal cells, it's actually looking for the virus that you'll be able to find before any cells start looking abnormal. And so people should be screened with HPV testing every 5 years, as long as it remains negative. And then if it's positive, there's a whole additional sequence of tests that will need to happen to see how advanced the infection is and whether or not the person needs any treatment.
Okay. You mentioned vaccination, that the recommended age is 9 to 11. If they miss that age range, can you talk a little bit about what age range can they still get HPV vaccination?
Yeah, so HPV vaccination is recommended up through the age of 26. Studies show that there definitely is population level benefit up through the age of about 17 or 18. But basically, the older the kids get, the less the effectiveness of the vaccination. And above the age of 20 on a population level, it's not great because so many people have already gotten HPV by that time. In the US, you optionally can elect to get the HPV vaccine between 27 and 45. Again, on a population level, that is not effective because most people already have HPV, but it's certainly something that is an option and may be helpful to prevent recurrence of a precancer in someone who's undergone treatment for cervical precancer.
Dr. Perkins, we have a related question coming in through Q&A and in the chat, and that's, if you had cervical cancer, would the vaccine be recommended?
I don't know of any studies about HPV vaccination after cervical cancer, but it certainly couldn't be bad, would be my thought on that, because clearly, you know, someone who's had cervical cancer is susceptible to having a bad outcome from the human papillomavirus, and the vaccine is very, very safe. So I would say the upsides would probably outweigh the downsides, but there wouldn't be any evidence that it would prevent a cancer from coming back, because at that point, it's not driven by the HPV, it's driven by the sort of cancer cell mechanism. So it would be sort of preventative against exposure to a future HPV, but it wouldn't be like a treatment for an existing cancer.
We also have another follow-up. If you get the HPV vaccine, can you still get HPV? And if so, why?
That is a simple question with so many parts. So if someone got the HPV vaccine later, after they already may have had HPV, then the vaccine isn't going to prevent the type that they already had, and that HPV can sort of come and go because it'll sort of sometimes pop out from what are called reserve cells in the cervix. So that might be one reason why someone who's gotten vaccinated tests HPV positive if they got the vaccine when they were like 22 or something like that. if someone got the vaccine, let's say in 2010, when we had the 4-valent vaccine, they might test, and let's say they got it when they were 11 years old, they still might test positive for HPV because the 4-valent vaccine doesn't protect against every single HPV type. And so they might be testing positive not for 16 or 18, which were protected against by that vaccine, but for some other type. Even the 9-valent vaccine that we've been using since, I believe, 2014 or 2015, there's still some types, there's still about 5 more types that don't cause a lot of cancer, but are in the HPV tests. And so you can still test positive for one of those other less dangerous types. And then sometimes, even if someone's been vaccinated, they'll have what's called a transient infection, which means they'll be exposed to HPV, they'll have a positive test for a little while, and then it will go away. So it's much less likely to progress to cancer, but occasionally you'll see like a little blip where they'll be positive for a little bit and then go negative. So it'll sort of reduce the severity of the infection, but occasionally you'll see a little blip where someone does turn positive and then negative again.
Thank you for that. I see there's another question in the chat that's moving towards screening. So before I ask that question, let's start by just, can you talk about the types of screening there are for cervical cancer, and what is the difference between the Pap test as a screening test and the HPV test?
So the HPV test tests actually for the presence of viral DNA. So it actually tests for HPV. It doesn't tell you, it tells you if you have an active HPV infection, but it doesn't tell you what's actually happening with the cells on the cervix. The Pap test, or cervical cytology, actually takes a little sample of the cervical cells, and the pathologist will look at them under a microscope to see what they look like, if they look normal or if they look abnormal. And so the HPV test is much more sensitive, which means it picks up over 90% of abnormal cells that are growing on the cervix, because pretty much everyone who has abnormal cells will be shedding HPV. And a lot of people are shedding HPV who don't even have abnormal cells yet. And then it's sort of used as a marker like, oh, we need to watch you more closely because everything looks fine right now. But, you know, in a year or two, we need to make sure this goes away, because if it doesn't, you could be at risk for developing some abnormal cells.
Mm-hmm.
The Pap test is looking at those cells to see how they look. And it's a little bit less sensitive, which means, you know, you could not get the right cells, or maybe there's only a couple of abnormal cells and you miss them. So you want to, it's not quite as good as a screening test because you're more likely to have a false negative, but it's really, really good when someone has an HPV positive test to figure out what's going on and whether or not they need to go and get a biopsy.
Okay. Thank you. And so along those lines, with the screening guidelines, ACS screening guidelines in 2020 coming out, changing the age range, recommended age range for cervical cancer screening beginning at 21 to now 25. Can you talk a little bit about the recommended screening guidelines? And one of the questions in the chat about that was kind of speaking up. This person says, there's a lot of confusion related to the time intervals between screenings. Women in general, in the general population, are confused on the 5 years versus the 3 years. How can we address this at the community level?
That's a great question. So basically, the better the test is at picking up precancer, the less frequently you have to do it. So when you're doing an HPV test, as long as it's negative and the person hasn't had abnormals, you can repeat it every 5 years, because the risk of them developing not even a cancer, just a precancer within those 5 years is less than 1 in 1,000. So very, very, very unlikely that anything bad will happen within that 5-year period. With the Pap test, because it's not quite as sensitive, it doesn't pick up every abnormality every time, the risk of getting a precancer over the next 5 years is about 1 in 200, so quite a bit higher. And so that's why you have to repeat it more often. You have to repeat it every 3 years, because you miss a few things, and so you need to repeat it to make sure that you pick up everybody on that second round.
Okay, thank
And
you.
did you want me to talk about the 21 versus 25?
Yes, yes, please. The change in age, the change in the beginning age for screening.
Yeah, so there are two reasons underlying that. One is vaccination works. Vaccination is really awesome. We have seen in countries, sadly not our country, but in countries that have achieved 80% vaccination rates, of which there are many, Scotland, UK, those are one country, sorry, Australia, the Scandinavian countries.
Denmark, yeah.
Yep. They don't have cervical cancer under age 30 anymore. They just don't. It has vanished from the population because everybody's been vaccinated. Scotland published a paper. They're like 0 cases of cervical cancer in people who are vaccinated. It's completely incredible. And this is the power of the vaccine, which we have not yet harnessed, but that we can. I believe we can. But even though we have not gotten to 0, we have gotten down very, very low. So the amount of cervical cancer in the 21 to 24-year-old age group is so low that screening isn't really going to do much because there's nothing to find. That being said, and the other thing is, starting with the HPV test at 25, you're starting with a more sensitive test. So anyone who might have anything going on, you're going to pick them up at 25 before anything bad happens to them. That being said, women between the ages of 21 and 29 are not screening. This is a problem. You need to, if you're supposed to start screening at 25, you need to actually start screening at 25, not 27, not 29, not, oh, I forgot and now I'm 32. No, you need to actually start at 25. So that is starting at 25 with HPV testing will work now just as well, if not better, as starting at 21 with a pap test, but people actually need to start screening. And we've seen a big drop off in screening at all in women under 30, and that's a problem.
Okay. You spoke a bit about the importance of and the effectiveness of the HPV vaccine, that it works. One of the questions in the chat was if the vaccine was taken at age 11, does the efficacy wear off by middle age? And she said, continued, I believe there is no guidance to revaccinate.
That is correct. There's no guidance to revaccinate because we believe it does not wear off. Their studies are ongoing. So far, they go out about 14 years, and there is no drop off in the antibodies. And what I learned from Amy Kramer, who's a very excellent NCI researcher at a meeting, is once you get beyond about 10 years with a vaccine, if the antibody levels are still high, that means it's created a type of memory cell in your immune system that is permanent. So we have other vaccines that last your whole life, like the hepatitis vaccines. We now give those at birth and they last forever. And so HPV appears to be acting the same way. We haven't had it for 40 years yet, but really once you get beyond that 10-year mark and you still see those antibodies nice and high, which we do have and we do see, it is expected to be lifelong because that indicates that it stimulated a particular type of memory cell that doesn't go away.
Thank you. A question about the about screening and what is the latest age for screening? I know that depends on a lot of things, on HPV history, whether they still, have a uterus. Can you talk a little bit about that?
Yes. So if someone has had their cervix removed or had a hysterectomy, including removal of their cervix for fibroids or bleeding or anything that didn't have to do with HPV or cervical cancer, doesn't matter. They could be 23 years old. They are done. They have no cervix. They do not need to screen. On the other hand, if someone still has their uterus and cervix, then they need to continue screening at least through the age of 65. People may stop at 65 if and only if they fulfill the following criteria. Number one, sorry, got to get in front of my face. Number one, they have had at least 2 negative HPV tests or 3 negative pap tests in the past 10 years. Number 2, they've had no abnormal results in the past 10 years. Number 3, they have no history of cervical precancer in the past 25 years. Number 4, they have never had cervical cancer. Number 5, they are not immunosuppressed. If and only if they fulfill all these criteria, then they can stop screening. Unfortunately, several national studies show that only about 30% of women fulfill these criteria, and people stop screening them anyway. And this is why we see cervical cancer in women over 65. In fact, fairly high rates with twice the mortality because they're detected by symptoms and not by screening. So over the age of 65, if you fulfill all those criteria, please go ahead and stop screening because you will be fine. But if you are one of the 70% of women who do not fulfill the criteria, please continue to screen until you do. The most common reason why people don't fulfill the criteria is they didn't screen enough between the ages of 45 and 65. People have finished having babies, they don't need birth control, they stop going to the gynecologist, and then there's just not enough screening around the perimenopause, menopause, and that leaves women at risk for cervical cancer over the age of 65. So please continue to screen until you meet all those exit criteria.
Yeah, our next question is kind of similar along that, and I think you may have intentionally answered it, but I'll still read it anyway. This person says, I had an abnormal pap with HPV in 2019. I had a LEAP procedure and all abnormal cells were removed. I've had pap smears annually since, and pap and HPV tests have all come back normal. Should I be testing annually now? And then as a side note, this person does have lupus, but is not on any immunosuppressant medication.
So once you've had 3 annual negative pap and HPV tests, then you can screen every 3 years with an HPV test or a co-test, but you should continue to screen at least for the next 20 years since it was in 2019, so that was 5 years ago. At every 3 years, and then I don't know how old you are, but if you're less than 65, at least every 5 years until you're 65. And there's the option, if you've had a CIN3, you certainly can continue to screen as long as you're in good health.
Thank you for that. And this person in a comment says that it sounds like if you had cervical cancer, it sounds like you should screen forever.
Yeah, so cervical cancer, sort of depending on what was done, the oncologists will have different recommendations because sometimes screening after radiation may be incredibly difficult and they may recommend other things. But yes, someone should have a treatment plan from their oncologist, and the regular screening guidelines wouldn't apply.
Okay. These are wonderful questions in the chat. Please keep them coming. We're really enjoying your input and engagement. So we'll continue. You know, with the age that we're in, there's so many reasons for people to be moving, either for work or for family reasons. Why is it important that people understand the results of testing that they've done in the past and keep their own medical records in case they end up moving or for any different reasons need to change their primary care provider?
This is a great question. And this applies to cervical cancer screening, but really applies to all of your healthcare, because when you move, your records often don't come with you. And if you need special medications or have allergies or need treatments or whatever it is, it's always really, have had surgeries in the past, it's always really important to have those records with you because they can sometimes be harder than they should be to obtain. In terms of cervical cancer screening particularly, it didn't used to matter that much when everyone was getting an annual PAP because everybody was treated the same. Everyone was essentially treated as very high risk. But we now know that not that basically nobody needs an annual PAP. Some people, however, do need more frequent screening, and some people need less frequent screening. And it will be very difficult for your new healthcare provider to figure out what you need if they don't have your medical records, and a record of, if you were HPV positive, when was it? Did you have a biopsy? What did the biopsy show? All of those things will impact how frequently you should get screened. So it's very important to make sure that you have the records so you can take them with you and show your new healthcare provider.
Thank you. Is there, so a common question that those who test positive for HPV may have is there any treatment for their partner, or is there any way to mitigate, spreading HPV to their partners? What would you say to that?
So this is a very common question. If it's a long-term partner, both you and the partner probably either have or have had the HPV, so you don't probably need to change your behavior because the cat's already out of the bag at that point. And so you don't have to worry about, doing any damage to your partner or having any problems from that. If it's a new partner, condoms are definitely helpful to prevent HPV transmission, although they are not 100% because HPV can be in skin that's not covered by a condom. And the other thing is HPV, there are many types of HPV. As I mentioned, the current HPV tests for 14 types, and really only 1 or 2 of them have any detrimental health impact on men. So HPV-6, the types are all numbered, and HPV-16 is the most aggressive type in women and men, and it's responsible for most of the cancers that are found in men. So if you don't have HPV-16, your partner is very unlikely to be affected.
Right. And there are 2 questions. I'll probably read them together because I feel like they can go together. If HPV is so common, why are there not other screening options beyond a pap smear? And is there anything that can be done outside of vaccination and screening for cervical health?
So in terms of screening tests, there's the HPV test is really the best screening test, and it's so incredibly sensitive. We don't really need a better test because it's a really, really good test. When you have the HPV test, if it's positive, then we actually have a number of different ways to figure out what's going on. So one is the pap test that I talked about, which is looking at what's called the morphology of the cells, or how the cells are shaped and what the nucleus looks like and what the color is and that kind of thing. And that will tell you, and that's a good indication of what's going on. There's a newer test that was recently FDA approved called dual stain, which stains the cell for P6 markers called P16 and Ki67, which are markers of cell proliferation, or how often the cell is multiplying itself, or cell growth. And the other one is cell transformation. So is the cell normal, or is the cell looking like a cancer cell? And so if the dual stain is positive, then that also indicates a potential higher risk for cervical precancer. And so those tests help you know whether or not you need to go and get a colposcopy, which is a procedure where we do a biopsy to figure out if there's any precancer that needs treatment. There's also another type of test in development called methylation, which is going to be, when it gets out, it's going to be even better. It's under development. They haven't quite worked out the kinks yet, but that tells you even more clearly whether a cell is turning into a precancer or not. So there's a lot of good stuff on the horizon in the field of cervical cancer screening, specifically of how to manage people who are HPV positive. And the other thing that I forgot to mention is a lot of tests now can tell you which type of HPV you have. And so HPV-16 is the most dangerous kind. And then they sort of go down from there. I won't list all the numbers, but there are HPV-16 is the highest risk. And then there's a group that are intermediate risk. And then there's a group that have a lower risk. And so, you would do more aggressive follow-up of an HPV-16 and maybe less aggressive follow-up of one of the lower types.
So currently there aren't any HPV testing available for men, but are there anything that's coming out on the horizon? There's one, that's one of the questions from the comments.
There is not, to my knowledge, an HPV test in development for men. The reason that it's easier to do an HPV test for women vaginally is because the cells sort of shed or exfoliate in the vagina, and so you can put a little swab in there and pick up some cells painlessly and send them off and you're done. But because the penis is dry skin, in order to get cells, in research studies they've used kind of like a penis nail file to try to get the cells, which is just not something that would really be sustainable in a healthcare setting. Here, take this nail file. No, thank you very much. So they have not gotten very far with that. Something that I know they're also trying to work on is figuring out gargles or ways to detect HPV in the oral cavity. And I think that's a little bit further along. That would obviously be for anyone who has a mouth, which would be men and women and everyone in between. But that also is still in development.
Okay. And are there any genetic testings that can be done for cervical cancer?
I'm not quite sure what that question means. Is that like to see if someone's genetically susceptible to HPV? And not that I know of. There's not, so, oh, I think I know what this is asking. This is like,
yeah,
like a BRCA or something like that.
Yeah, they made a comment of that there is for breast cancer, and so they're just wondering if there is also one for genetic testing for cervical cancer being predisposed for that.
There isn't, because it doesn't seem to run in families like breast cancer and some of those other colon cancer, some of those other sort of familial cancers, because it's caused, unlike those cancers, which may be hormonally related or something else related, this is related to a virus that people typically are exposed to when they themselves are adolescents or young adults. So there does not appear to be the same sort of familial genetic risk for cervical cancer the way there is for breast cancer and colon cancer.
Okay. If you're along those lines with for women who may have abnormal cells on their cervix, is there any risk of transmitting that to a child, to a baby, as if they gave birth?
So generally, no. There is a very rare condition called recurrent respiratory papillomatosis, which is if a mom has genital warts and gives birth. Extremely rarely, the baby can get warts in its mouth and trachea. That also is something that has completely disappeared from Australia and other places with vaccination. But it is something that is seen, but it's a very, very rare condition.
Okay. That's good news. One question is, what are your thoughts on HPV at home testing? I believe that may be referring to the new testing that's coming out for screening for HPV.
Yeah, so self-collection, which means an individual taking a swab or a brush and taking a sample from the vagina to test for HPV, was approved in May by the FDA. However, it was approved at this time for use in a clinic setting. So that means at your doctor's office, maybe in a laboratory setting, but it's only, by prescription of your doctor or healthcare provider, and it's only for 2 tests. So you can go on Amazon and get some HPV test in the mail, but that is not an FDA approved test. So I would not recommend doing that. You want to make sure that if you're doing a self-collection, that you're getting it from your primary care provider's office, because otherwise it may not work because it's not FDA approved.
Thank you for that. And I'm glad that our viewers are aware of the the HPV self-test that's
Yeah.
that's recently approved. So kudos to everyone here.
Yes. And they're doing, and it may become approved for home testing in the future. It probably will. But those trials are currently underway, and they have to make sure that that it functions just as well if, you know, it's the thing is sent home and then it's sent back in the mail and nothing degrades, and then it still is very sensitive. So for now, it needs to be done in a controlled setting to make sure that there's no false negatives.
That's right. Our time is quickly coming to an end. And so I'll end with, well, I'll ask this one more question before I turn it back over to Shelley. Maybe we have time for two. So does HPV disappear forever, or does it come back?
So we used to think it disappeared forever, but now we know that sadly that is not the truth. It may disappear forever. Almost everybody will test HPV positive at least once, and it may never be seen again. However, it definitely can come back. And the most common reason for a new positive HPV test among women in midlife who are either not sexually active or are in long-term monogamous relationships is a reactivation of an old infection. So I always tell my patients, a new HPV positive test is not a reason to get a divorce. It's probably an old infection that's rearing up again. On the other hand, chlamydia, different story, but a new positive HPV test should not be a cause, maybe for a conversation, but not for a divorce, because it's probably a reactivation of an old infection.
That's good to know. Hope you just saved many relationships with that sentence.
I hope so too.
Okay, and I know that we're running, so I'll ask one more question that just came in, and then we'll end it with that. What are your thoughts on other sample types? I'm not quite sure what this person asking, but what are your thoughts on other sample types other than vaginal swab that can be good for HPV detection in the future? I'm not sure if this person means if other tests that maybe detect HPV, if it's other than a vaginal swab.
I'm not quite sure what they mean, but it is sort of, it's a local infection. It's not a systemic infection. So I don't think there will ever be like a blood test that will tell you if you have HPV that's active anywhere in your body. So, you know, if there's more testing in the future, it'd be like, oh, there's a test for the mouth and there's a test for this body part and that body part. It would be unlikely to be sort of a universal test.
Right. Okay, and so with that, I would like to thank the audience for you know, their wonderful engagement, wonderful questions. And I will turn it back over to Shelley, who will just close us out. But thank you, everyone.
Thank you so much for coming.
This was an absolutely fantastic event. Thank you, Drs. John and Dr. Perkins. We really appreciate having you here and having your expertise. It's so rare that people in the community get the opportunity to speak with the leaders and people who are so versed in this information, and it's so critical to get this information out there. So we do appreciate your time. If we were not able to get to your question, there was like one or two questions in the chat that we didn't quite get to. We will try to answer those in the comment section on our YouTube as we put underneath this. If you're looking for additional information, you can always find information on the ACS National Roundtable website. We have that link here. Also, there are resources in our resource center to help you out. And then if you're looking for more information on cervical cancer basics and you're looking for verified, scientifically correct, good information, stay away from Facebook. That's not the place to go. You want to go to the American Cancer Society, the Center for Disease Control and Prevention, and the National Cancer Institute. And we've provided those links for you in the chat as well. Thank you very much. Thank you very much for your positive affirmations that are pouring in through the Q&A and the chat. We really appreciate that and your time, and have a good evening.
Good night.
Night.
Good night.